My name is Veruschka Pandey, and today I'll be presenting on something very close to my heart. My 4 year long youth led mission using research and policy reform to transform type 1 diabetes care in low and middle income countries. But before I begin, I'd like to briefly introduce myself. I currently serve as the WHO Youth Ambassador for Non Communicable Diseases from India, and I was one of the two sole youth representatives from my country to have a documentary on my CPR initiative, Project Suryanayak, screened at the United Nations Youth Summit 2023. I'm the principal investigator of India's first youth led qualitative study on type 1 diabetes mellitus, which I will be presenting in today's presentation, with the Public Health Foundation of India, where I also serve as a youth champion for the past 4 years. Today's presentation is about a lived journey through broken systems and misdiagnosis, through grassroots stories and global comparisons, and through evidence and empathy. Let us first pause and take a look at the issue we are here to talk about. Not a rare disease, not a fringe issue, but one of the most urgent and under-addressed public health failures of our time. The global landscape of type 1 diabetes mellitus, especially in low and middle income countries. Over 8.75 million people live with it globally, but in LMICs or low income countries, type 1 diabetes is not just a manageable condition, it's a death sentence. According to the IDF, nearly 1 in 2 children with type 1 diabetes mellitus in these regions die before the age of 20, not due to the disease itself, but due to the lack of insulin, misdiagnosis, and systemic neglect. These are not isolated cases, they are symptoms of silence in data, policy, and global prioritization, and that silence is what I set out to challenge. So while the global numbers were shocking, it was what I saw on the ground that truly changed everything. It began in rural Karnataka, the state I'm from in the south of India. During a CPR session I was leading, a student collapsed. She was later found out to be hyperglycemic. But there were no kits, no plans, and no nurses. That moment was unique. I began documenting similar stories: girls hiding insulin to avoid stigma, health workers unable to distinguish type 1 diabetes from dengue, and soon I expanded my lens, tracing the same structural gaps in Bangladesh, Bolivia, and Kenya. That's when I realized this wasn't just India's failure, it was a structural disregard for youth with type 1 diabetes across the global south. At 14, I published a comparative policy review through Innovapolis on how countries like India, Kenya, and Brazil address or ignore type 1 diabetes compared to other high income countries such as UK, Sweden, and Australia. In low income countries, the stories were the same: no insulin, no training, and no school protocols. In high income countries, everything from legal safeguards to personalized diabetes care plans. This wasn't just about funding, it was a philosophical divide. One model protects, the other abandons. And that policy divide is what I set out to reform. At some point, data is no longer enough. Statistics lose meaning without stories, and evidence without empathy fails to move systems. I reached that point. After months of documenting gaps, critiquing policy, and analyzing cross country failures, I realized that critique alone wasn't going to do enough. That's what led me to design and lead India's first student initiated qualitative research study on type 1 diabetes mellitus with the support of public health experts and medical mentors. We spoke to 43 participants and used purposive and snowball sampling, reaching communities across my state's urban and rural belt. The interviews were conducted in the regional language and using grounded theory, we identified 5 major domains where the system breaks down, from access and affordability to awareness, stigma, and mental health. And this, for me, was a turning point because this wasn't just about stories anymore, it was about structured, bottom up evidence. The thematic insights our study revealed to us were not just applicable to India, but actually could be broadened to several low income countries. We found number one, infrastructure failures. One nurse said that we don't even have glucose strips most weeks. These stockouts were very common, and this challenge is echoed across many low income countries where public supply chains often exclude chronic care essentials. Number two, misdiagnosis. A child had 3 seizures before being diagnosed with type 1 diabetes, emphasizing on the absence of provider training through CME, continuing medical education programs. Number three, gendered exclusion. A girl stopped attending school trips due to shame and lack of support. This gendered burden has actually been studied in several other low income countries as well. Number four, financial collapse. A father told us that he spends half of his income on insulin. This is a crucial issue across all LICs where essential diabetes supplies are rarely covered by national insurance schemes. And number 5, mental health breakdowns. A mother shared that she cries when her daughter sleeps. Over 75% of caregivers in our cohort reported psychological distress. 6 in 10 children faced school based bullying. Yet, there was no mental health infrastructure in schools or clinics. These voices made one thing very clear: type 1 diabetes is not just a clinical crisis, it's systemic, emotional, and deeply human. However, our research wasn't just meant to identify gaps, so we built a multi stakeholder policy blueprint which is applicable across all LMICs and is not just country specific to India. First, national governments must formally recognize and include type 1 diabetes mellitus within their non communicable diseases framework. They should create ring fenced budgets, national procurement plans, and cold chain supply chains. The infrastructure already exists. Insulin and glucose monitoring tools must be treated as essential medicines and delivered through the same systems used for other communicable diseases such as HIV and tuberculosis. Number 2, education ministries must implement diabetic emergency protocols in all schools. Teachers should be trained to recognize symptoms, administer insulin, and respond in real time. In countries like Nepal and Philippines, this can be integrated into existing school health programs. Number 3, healthcare providers, especially in rural and peri-urban areas, need continuing medical education CME on type 1 diabetes. In India, this can be deployed via the Ayushman Bharat Digital Mission, a tele-educational platform over here, and other nations can adopt similar digital platforms as well. Fourth, community health workers must bridge the gap between chronic care and community reach. Whether it's the ASHA workers in India, CHPS workers in Ghana, and FCHVs in Nepal, these frontline workers can integrate type 1 diabetes screening and caregiver education into their regular maternal child health visits. This is low cost, scalable, and proven to increase early detection and treatment. And finally, the youth. Young people are not just patients, we are leaders. Through school awareness campaigns, peer led clubs, and youth led data collection, we can reshape public attitudes, reduce stigma, and help communities respond faster as well. This roadmap is not idealistic, it's implementable, using existing systems, enhancing workforce capacity, and centering those who are the most effective. In fact, to prove it's implementable, we piloted 2 programs in our state of Karnataka. One through school health clubs, training students to identify diabetic emergencies, and number 2 through a caregiver education and initiative, embedded into maternal child health services, offering early detection tools, insulin education, and mental health support. These models are ready to scale across all low income countries. The infrastructure exists. We just need to plug in policy, training, and accountability. To conclude, here are the references used for this presentation, and I'd like to express my deepest gratitude to my parents, to Dr. Giridhar and the incredible team at Public Health Foundation of India. Thank you for mentoring this vision into something real and evidence-based. To every participant in the research who trusted us with this story, to governmental departments for recognizing the value of community-grounded reform, and finally to the Global Health Leaders Conference, thank you for giving me the platform to speak not just about an urgent crisis, but to help bridge it. Thank you, and here's my contact information.